All right, so this is going to be a combo part 1 and 2 for chapter 13 in your blue pharmacy practice for technicians. So sterile and hazardous compounding. So the nature of compounded sterile products, the chemical properties of the IV solution, so the pH value of a product, the degree of acidity or alkalinity of a solution. So blood plasma pH should be about 7.4, and an IV solution pH should be 7.0, which is neutral. Okay. Osmolarity is a measure of the number of milliesomoles of solute per liter of solution. Osmotic pressure is a pressure required to maintain equilibrium with no net movement of solution across body membranes. Compatibility is the ability to combine two or more additives in a solution without any physical or chemical changes in its properties. Stability is the various conditions that we store these sterile compounded products in. Some are refrigerate, some are keep at room temperature, some are protect from light. So there's different ways that we store these. Hypotonic solutions. An example of a hypertonic solution is 0.45 sodium chloride or half NS, normal saline. That means there's fewer dissolved particles than blood. Hypertonic, so hypo and hyper are two different. Hypertonic is more dissolved particles than the blood, so it's higher amount of particles compared to the hypotonic. So an example with this is that water is drawn out of the cells, causing them to shrivel in hypertonic solutions. So an example of hypertonic solution is 3% normal saline or sodium chloride. Isotonic solutions are similar number of dissolved particles as blood. So an example would be 0.9% sodium chloride. And that's one of the reasons that we use the 0.9% sodium chloride or NS, normal saline, for patients in most of their IV bags. We use it when patients come in dehydrated and that type of thing. So an overview of the sterile compounding process and components. So first, after receiving the med orders and labels, the pharmacist will perform the initial calculations. They will perform any remaining calculations and initiate the compounding record. The window or the wipe down supplies. Okay, so as you're getting ready to go in and make these compounded sterile products, you are going to be done and garbed first before you're going into the IV room. You're going to make sure you're wiping down all of your supplies that you're taking into the sterile area. You'll follow aseptic technique for garbing and hand washing. You will transport the compounding supplies to the buffer room. In the buffer room, you will sterilize your hands and then put on your sterile gloves. You will clean the hood, the IV hood, per USP Chapter 797 guidelines. There's a video, I believe on Thursday or Friday, I have posted for you guys to watch on how to clean the hood, and that'll be something that we practice when we get back. Compound the compounded sterile product inside of the hood, again using all USP Chapter 797 guidelines. That means 6 inches in, not blocking your airflow to anything. You'll complete a quality check of the compounded sterile products. You're going to physically look at the bag itself and look for anything like precipitation, any gelling, any color changes, anything like that. The pharmacist will have the final verification of the compounded sterile product. They will verify the product itself, the label, and all of the ingredients that went into it. And once that's completed, the pharmacist will sign off on it. And then at that point, it can be delivered to the nursing units. So types of IV solutions. So a type of large volume or parenteral nutrition is a type of large volume solution that supplies nourishments to patients who cannot take sufficient food by mouth. Most of our patients that receive this are intubated, which means they are placed in a medication-induced coma. They have a breathing tube, so obviously they're not up and eating. Peripheral parenteral nutrition, known as PPN solutions, provide only part of a patient's nutrition, and this is kind of designed for short-term therapy or short-term use, 10 to 14 days. Total parenteral nutrition, known as a TPN, will supply the patient with all of the patient's daily nutrition, and this is given in particular for extended stays in the hospital. So when you have patients that either need PPN or TPNs, this comes from orders from the physician, and it also comes with so the physician, a dietitian, and the pharmacist are all working collaboratively on the orders for the TPN. They're looking at things like blood levels, certain blood levels of minerals and stuff that are in the blood, and how much the patient weighs. They take a lot of that into account, and those three entities work together to determine what and how much of the ingredients go into the TPN. Large volume parenteral, so they're used to replenish fluids, provide drugs and electrolytes and nutrients. So large volume would be available as 250 mLs, 500 mLs, and 1,000 milliliters. And these are typically administered over 1 to 24 hours. Your small volume parenterals are used to deliver medication. Those can be anywhere between a 25 milliliter bag to a 250 milliliter bag. And these are typically administered over 10 minutes to an hour. So smaller volume, smaller amount of time. And again, the majority of these are actually what they call IV piggybacks. So labeling requirements. So your order number must be on the label, the patient's name and ID number, the base solution and amount. So the base solution is what the IV bag is. Is it a normal saline bag? Is it a dextrose bag? The additives and the amount. So what is the drug that's going in it, the amount of drug going in there. The infusion rate, okay, how the nurse is going to be setting the IV pump. How is it administering? Is it administering over an hour? Is it administering over 4 hours? The beyond use date and time. Okay, so we have compounded it. We have taken it from its original form in either a powdered vial or a liquid vial. We've put it into an IV bag. That changes the date on the vial. Trissels is one of the resources that you can use. Anytime that you start to spend extended periods of time working in an IV room, you're going to start to learn those expiration dates, and they'll just be flowing off of the top of your head. Storage requirements. Okay, does it need to be refrigerated? Does it need to be stored at room temperature? Does it need to be protected from light? Device specific. Okay, is it a regular IV pump? Is it a PCA pump, which is a patient controlled pump, where they have a little button that they can control the amount of medication? That's typically for pain meds. Signature and initials of both the technician and the pharmacist. So on the label, it has to have the initials of the technician that made it, and then the pharmacist that provided the final check. Pharmacy information if it is sent to an outside compounding facility. So this would be, like your long-term care pharmacy sites that do bulk long-term care prescriptions for many different sites. They are located off-site, so it has to have that pharmacy information on there. And then any additional information required by the institution, the state, or federal regulations. Your master formulation record, similar to the non-sterile compounding, tested and approved recipe that lists the ingredients, specific procedures, and the equipment to be used to make a specific kind of compounded sterile product. And those include everything in that master formulation record is going to include the name, strength, and dosage form of the the compounded sterile product, the physical description of what the final product should look like, identities and amounts of the ingredients, complete instructions for preparation, the beyond use dating and storage requirements, the quality control procedures, and the sterilization method if applicable, because some compounded sterile products require a specific type of sterilization to take place before you do that. The compounding record is a list of every compound made based on the master formulation record. So again, name, strength, and dosage form, the master formulation record reference, date and time of the preparation, the initials of both the technician and the pharmacist, an internal ID number, name, vendor, lot number, and expiration of the ingredient, the name, lot number, amount of each ingredient, documented calculations, deviations from the master formulation record, total quantity compounded, so 250 mLs, 500 mLs, and then the beyond use dating. So compounding, common compounding calculations include measurement conversions, okay, so converting from milliliters to ounces or ounces to milliliters, converting from milligrams to grams, grams to milligrams, milligrams to micrograms, those type of things. Solving for a missing measurement using an equation involving equal ratios, using dimensional analysis to perform multi-step conversions, calculating the dilution of powders into solutions, and performing calculations involving quantities of milliequivalents. So inside the hospital or anywhere where you're doing compounded sterile products, you're going to be doing the more in-depth math than you would be doing inside of a retail pharmacy. So the overfill amount is the amount of solution and manufacturers add to make up for the loss of water due to the evaporation of the plastic. So manufacturer bags and bottles routinely contain more fluid that is listed on the package. So each hospital or infusion pharmacy will have a written protocol for dealing with overfill calculations. You're going to need to know this next part for your test, for your math test, actually, your math final coming up. So many pharmacies have a 10% overfill rule. 10%, okay? Small volume medication addition. So you reconstitute medications with a diluent. You will add, must administer the entire contents for full dose. So the instructions are letting the nurse know, do you infuse the whole bag? Do you use the entire vial? If not, how much do you use? Volume withdrawal or medication addition. So remove the volume of base solution equal to the volume of medication. Add the volume is constant. So the total volume is constant. So for example, there's a couple of specific drugs that we made inside of the hospital that we had to remove the same amount of diluent or solution from the bag as we were going to put in of the drug. So for example, when we made regular insulin IV drips, those were 100 ml bags. We would put in 1 milliliter of insulin. So before that, we would draw out 1 milliliter of normal saline and discard it. And then we would add in 1 milliliter of regular insulin to keep the total volume at 100 mLs. Some of the other drugs, it's not a big deal. And again, that's something that you'll learn. Your label will let you know if it's an overfill and if you have to remove something. Our Levofed drips were the same way. We had to draw out 4 milliliters of normal saline and then inject 4 milliliters of the Levofed. Large volume withdrawal. So remove volume from the base solution equal to the volume of medication to add plus the manufacturer overfill, which is typically an estimate. So necessary for intensely concentrated doses. This is in particular to chemo drugs. Newer container, use the precise amounts. Do not overfill. So that's saying if you are taking 2 separate solutions and putting them into an empty bag, you're going to use the exact amount. Technicians may need to calculate the correct amount of IV bags needed for a 24-hour supply. So that's why it's important to know how to figure out what how long it takes to run an IV bag, what is the flow rate in milliliters per hour, how much drug they're getting per hour, and then the last video that you actually watched for the drip rates in determining how many drops per minute that they're getting. Based off of those calculations, you can go in and you can determine how many bags, IV bags, the patient is going to need us to make to have them supplied for a 24-hour supply. So we're going to go ahead and pause there. If you have any questions, please give me a call, send me an email. I'd be glad to help.